monitoring and evaluation technical support program, and it's one of the projects under Makerere University School of Public Health. Our PI is Professor William Bazeyo, who is also the Dean of Marcus PH School of Public Health.
School of Public Health, through our teaching methodology, which is community-based teaching. We interact with the communities. In the process, we train the communities. So we are always building capacity at the district level, at the communities. We're always training the in-service, those people who are already in service. And for us to train them, we develop modules and the training programs that fit them.
Monitoring and evaluation technical support program is in the business of providing information for evidence-based decision making, and along its support to the Ministry of Health and the country in general in terms of capacity building initiatives for ensuring that we have good quality data that comes in on time, that is complete and accurate, has been the gist of our implementation. Primarily, the case-based surveillance project is part of our other capacity building programs or technical support initiatives.
In Africa, it was recommended by WHO for countries with generalized epidemics to start using HIV case-based surveillance in gathering patient information. The countries that are currently piloting it include Ethiopia, include Tanzania, include Kenya.
HIV case-based surveillance is, which we abbreviate as CBS, is a means of uniquely identifying HIV-positive clients, who in this case we call cases, and tracking them over time along the continuum of care. The continuum of care is a period from testing up to moving through eligibility for RT treatment, initiation of treatment, then monitoring through the treatment up to the time they improve, what we call, in our terms, viral suppression.
Currently, the reason we are now piloting HIV case-based surveillance is that the other surveillance methods we've been using over the 30 years in this country have had weaknesses of not telling us the accurate estimates of what we are dealing with, the accurate number of the people that are becoming HIV positive, the accurate number of the total population that we have that is HIV positive. Who are they? Are they females? Are they males? Are they children? Which geographical area is most affected? HIV case-based surveillance is following that one individual who gets HIV positive, and you follow them throughout their lifetime.
HIV is staged in four stages, 1 to 4. So we track progression of the disease from stage 1, stage 2, stage 3, or 4, for what we call the severe or advanced HIV disease. But also we track the opposite, how somebody, if started on treatment in disease stage 3, how he can move to 2 or he moves to 1. 1 is what we call actually asymptomatic.
And the districts that were selected included Hoima and Kabarore. When you are piloting any activity, you want to use a better site and a not so good site.
We have a challenge of HIV/AIDS. Certainly our prevalence rate is quite high, because where the national prevalence average is 7.3, in Kabarore as a district our prevalence stands at 11.3.
These patients we are talking about have a big number of them. You go to a health center or a hospital like Potopoto Regional Referral and you find 2,000 patients. Now these 2,000 patients, each of them has a record. And that is to say, they have a file with so many details in the file.
We wouldn't get all the details, and you find sometimes it would be somehow hard to track that patient when that patient comes back.
I highly believe that it is going to be better than the system we've been using. The fact that we have clients who enroll in different health facilities and you find one person is enrolled in 4 health facilities, therefore is increasing the HIV burden.
For the country to be able to uniquely identify clients so that if I am a client in care and I have tested or I am receiving treatment from facility X, I should be able to be tracked to the next facility. So within facilities, I'm easily tracked, identified and tracked, but also across facilities or even across districts once we're able to connect the facilities using available technology.
Typically, these health facilities have to collect and report data to the Ministry of Health. So, by aiding them in that process, we're strengthening the foundations, which is the data collection at the facility level. If you have a computer to help you better find information, find patients who have not turned up, who are lost to follow-up, who are due for tests, it sort of helps you speed up your analysis of data, hence improving care.
We have in our pilot districts that have procured computers, all the sites that have not been having computers. And in addition, we have procured solar systems to all the sites that have no power.
On the computers that have been installed in Kamaloli, we have installed on the latest version of OpenMRS, locally known as Uganda EMR, version 1.11.6. And in this revised version of OpenMRS, we have installed the latest HMIS data collection tools to capture HIV data, that is a HIV client card and exposed FAD cards.
We trained all the record staffs and the clinical team on how to run the electronic medical records alongside the paper-based system. Right now at the facilities we're implementing, health workers, specifically data personnel, are able to enter the records for LRT clients, for clients on ART, and also HIV-exposed infants. They're able to auto-generate reports. There's no more writing or counting the paper-based tools quarterly and monthly. Most of the Ministry of Health recommended reports. We also receive technical support supervision from the Ministry of Health on a quarterly basis to make sure that the system is up and running and the facilities are able to use this data. We do quarterly data review meetings to make sure the data we are generating is making sense, but also we're able to use it for decision making at facility and district level.
The next phase is to inform the Ministry of Health or the government of Uganda that these are the costs of HIV case-based surveillance. This is the rollout process that we took in these pilot districts, such that the country can look for resources of national rollout.
Investments in technology, like the METS project, will further help government to put resources to areas that give us the most impact. Because we will be able to characterize the epidemic in terms of geographical location or sub-counties with the greatest burden, and the actual numbers of infected people.
To me, this is hope restored. And with this hope restored, certainly, I look forward with a lot of expectation because we are going to get good results which will inform decision making, which will inform the planning process both at the national and at district level, and as far as the sector of health, particularly the burden of HIV/AIDS is concerned.
I'd like to thank CDC Centers for Disease Control and Prevention, both Uganda and Atlanta, for supporting the school, not only the school, but the College of Health Sciences for the several projects that we run, and supporting the Ministry of Health, helping us support the Ministry of Health to build capacity and achieve Ministry of Health goals. I'd like to thank the partners that are there in the field, who are not necessarily CDC that we work with, the development partners that we find in the field. I'd like to thank the districts for accepting to work with us to develop programs that are meaningful to their operations. We thank them, and we believe that we'll continue to work together and cause great change in our country.